I met a woman from one of the group sessions that we had. She was a cancer survivor of more than a dozen years. And she said when she was first struck with cancer, she never knew a survivor. She didn't know that that was possible. And that really changes how you think about engaging. While genetics loads the gun, environment pulls the trigger.
I get asked a lot of questions when I'm out in the community talking about breast cancer in Komen, Austin. Without a doubt, the two which are asked the most are, what causes breast cancer and how can I prevent it? If we knew the answers to those questions, I would gladly be out of a job. But we do know that being a woman and getting older are the two biggest risk factors. I, for one, love being a woman, and getting older is a pretty great thing that certainly beats the alternative. But another significant risk factor is being a woman of color. And it turns out it has little to do with genetics. Dr. Virginia Brown works at the Dell Medical School here in Austin, where she has served as the Director of Health Disparities Initiative, and she's now the Assistant Professor in the Division of Community Engagement and Health Equity in Population Health. Her focus is health disparities, and we certainly see that in the breast cancer arena. Dr. Brown, let's start by help me understand, what does health disparity mean?
Okay, that's a really important question. And what I want people and for our conversation today is understand a couple things. When we talk about two things. We talk about health and healthcare disparities, and we talk about them between population groups. So first there's health disparities, and then there's healthcare disparities. And we know that there's differences because we're looking at population groups. So more specifically, when we're thinking of a healthcare disparity, we're thinking and talking about differences between groups, between health insurance coverage, who has insurance, who doesn't, the kinds and quality of insurance that people have, access to and use of care. There's a big difference between sometimes living in an urban setting versus a rural setting versus a suburban setting about access. Can I get there? You might think in an urban setting, hey, there's all kinds of healthcare providers in the urban setting, but if I'm reliant on public transportation to get there, my access may not be the same, right? And the third component when we talk about a healthcare disparity is we talk about the quality of care. So even if I got there, am I receiving the same standard of care as everyone else? These are some of the features that lead to health disparities, right? So when we're talking about what is a health disparity, we're talking about a particular kind of health difference that's linked to social, economic, or environmental disadvantage. That health disparity looks at the outcomes. We see a greater burden of disease and death in a health disparity. We see it across racial or ethnic groups. We see things around socioeconomic status and gender. It's a wide range of health disparities that we're thinking about. So we're teasing out two different types of issues around health. Does that make sense?
Absolutely. So this is a really complicated subject matter. It's not just as simple as what your zip code is, although that certainly is a part of it.
Right. It's certainly a part of it. It is the result of it, right? So there's this thing that happens in between, like how do we get there? Why do we see this zip code thing that you suggested? There's another word that we use. You might hear this in discussion, social determinants of health. So there's this concept when we think about health, and if you ever talk to geneticists, I started studying. I'm not a geneticist, but many of my friends were when I got into doing the kind of health and healthcare equity work that I do. And my genetics friends would always remind me that while genetics loads the gun, environment pulls the trigger. So what does that mean? Yes, we may have genetic predispositions. You know how people say, well, it runs in my family?
Right.
And we might not yet know in unraveling the genome the exact combination of genetic sequence that says blah, 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 right? But we have this sense that it runs in my family. Well, that's the genetics. It may load the gun, but it is the environment, how we live, where we live, what we have access to, the physical environment that surrounds us that makes those genes express. So those social determinants of health have a significant impact on health outcomes. And we think about them as the structural determinants in which people are born, grow, live, and work. So here in Austin, we have a very real structural determinant that runs up and down this I-35 corridor. And we have something called the East Side, and we have something called the West Side. And the East Side was socially engineered to move black and brown people to the east side of the city along with the polluting businesses back in what they call the master plan of 1928. So when you think about how does that get down to the zip code level, right?
Right.
And how does the difference between my sort of genetic predisposition, if you will, and the environment, living in communities that are not resourced to their highest level, that may have pollutants in the air or in the buildings or in the food that may be contaminated by the ground that it's grown in, these can make diseases express in different ways than if you're not exposed to them. And we also hear this other term, it's a popular term, microaggressions, sort of the living while black or living while brown, the kind of experiences that black and brown and other minority people experience, is a day-to-day stressor that can make the body behave differently when under stress. It will make any body express disease, possibly, right? Anybody subjected to ongoing aggression, disenfranchisement, these kinds of things. It makes you uptight. It makes your blood pressure go up. It makes all kinds of things happen to the body that can make disease express. So when we start talking about how do these differences map out to zip code, we see it very clearly in the leading causes of death here in Austin and where the highest mortality rates are for all of the leading causes of death. They really do vary from the east side to the west side of the city, and they're at the zip code level, and it's very startling.
It's really fascinating when you put this in context and understand how in Austin that I-35 corridor is an absolute divider. Mm-hmm. When we bring this to breast cancer, mm-hmm. we know that in Travis County, which is Austin, both sides of 35. So when we look at Travis County, we know that breast cancer is the second leading cause of death in women, mm-hmm. which is tremendous. But then we also know that African American women are 44% more likely to die from breast cancer than any other ethnicity. Right.
And the question really, Susan, is there something about my ethnicity? Like, is it me being black or me being brown or me being white?
Right. Is it genetic or is there something else? Because
exactly.
Really, I think there's something else.
There's something else. Because if we understand what we learn from the decoding of the human genome, what we know for certain is that there is nothing in that genome that codes for being black, brown, or anything else. There's nothing in there that says, oh, this is the DNA of a black person. But because of the way this country was founded in a very racialized way, we do look at discrete groups. And in looking at these discrete groups, we're seeing differences, and we call the groups black, and we call the groups Hispanic, and we call the groups white. And we say there's differences amongst these racial groups, as if we are reinforcing the idea that race is real, right? So I want to be extra super clear that race is a social construct. So what is it that we're saying when we realize that 44% more of these deaths are experienced by black women? What's going on? They're black, but is it that? Because, like, you can't change my blackness.
No. So
No.
No, you can't. And so what's really fascinating is when we listen to you explain how what these social determinants really do and how they really affect your health. Well, all the way from pollutants in the air to social stressors, to that microaggression that you're talking about, and access, and then quality of care as well. So there's this barriers at really high levels to not only to care, but then also just to be healthy.
Exactly. And so, the academic in me had to prepare a little bit, because cancer isn't my space, but disparity is. So I analyze things through understanding what is health and healthcare disparity, and how do these social determinants of health show up. So I did a little digging. I didn't have to go far. Pulled a couple articles, and I want to just read to sort of reinforce some of the things you said. A quick sentence or two, if I may.
Absolutely.
Okay, so this is from an article from The Oncologist: Disparities in Breast Cancer Treatment and Outcomes, Biological, Social, and Health System Determinants and Opportunities for Research. And one of the things it noted is that if certain subpopulations receive, and this is really important, receive less than standard treatment, i.e., treatment appropriate for the features of the cancer, differences in outcomes are likely to result. Black women, more often than other women with the same stage disease, fail to receive timely diagnosis and recommended treatment for breast cancer. That's a healthcare disparity.
Absolutely.
An issue, around access and quality. And these are critical things that we need to step back if we're trying to figure out what are the right interventions. How do we work to engage not only consumers of care, but providers of care, to understand their patients and meet them where they are, right? At whatever stage, not of the disease, that's critically important, but sort of mentally where you are in accepting and understanding this diagnosis. I met a woman from one of the group sessions that we had. I saw her elsewhere, and she said to me, she was a cancer survivor of more than a dozen years. And she said when she was first struck with cancer, she never knew a survivor. She didn't know that was possible. And that really changes how you think about engaging. If you don't know that cure is possible, it may ring as a death sentence, and one's ability to hear and interact. I mean, I had a low-level issue, not with cancer, but I had a knee replacement just recently, and trying to understand that I really needed it a long time ago had a whole lot to do with the way the providers were talking to me, treating me. And this is the space that I live in, right? This is the work that I do. And I couldn't become engaged in a conversation to help me understand the nature of my disease, the progression of it, the symptoms, what it was doing, until my knee just actually almost gave out. And it was like, I don't think I have many other choices. Now, if I equate that to having something as serious as a disease that could be fatal, and if I don't understand, if I'm not at the center of the conversation, I am the patient. It is my universe, and people need to meet me where I am so that I can understand my options. That's the first tenet of medical ethics, is to do no harm. And to do no harm is to work with our patients to get them to understand what the risks, the alternatives, and the benefits to this treatment is, and to work with them until they're there so that they can make the best choices for themselves as early as possible, because that's really critical.
Completely critical. I want to back up just a second to what we talked about. You talked about timely diagnosis.
Yes.
So this is something from a Komen perspective that we preach. You've got to go get that mammogram, because when we know that if we catch breast cancer between stage 0 and stage 3, if you get it before stage 3, you are 99% likely to see the next 5 years of your life. And then after stage 3, we're all the way down to 60%.
Mm-hmm.
So we look at African American women, and we know that they're not getting diagnosed in a timely fashion, which is one of the reasons that they are that mortality rate is so high.
Mm-hmm.
So what's the solution there? What is that barrier to that initial screening? Not even just for breast cancer, but for everything. That primary care. Hey, you need to get this test done. Hey, you need to be screened for this. What's that barrier, and how do we fix it?
Well, I'll give you a real life example that I bumped into from where I used to live when I went to get my mammogram. I think I was talking. This was in Washington D.C. I was talking to some of the folks there. Long story short, this delay of getting to care, they realized in their mammography center that the delay in part of women returning. You get a suspicious screening and you need to return because we see something. We're not quite sure, but we need to call you back in. What this center had been doing was sending out certified letters to people that you had to go pick up, from the post office. Certified letters in most communities mean a bad thing. So
yes.
I'm not going.
I don't want to sign for a certified letter.
I don't want to sign. Yeah, neither do I. I'm like, no. If you can't call me, I don't know you, and this isn't good news. It's not.
No, I don't want to know. I don't want to know what's in that envelope.
No, exactly. And this had been their method, that they were sending out these certified letters. In part, I would suspect, it's a kind of CYA move in a clinical perspective. Well, we tried to reach them. We have proof that we tried to reach them. See, we sent out a certified letter, but hey, they never came back. We're off the hook.
Right.
I mean, that's a very, glass is half full kind of view. But I know that was part of the thinking, that we have to reach out to people. So I don't know how they came to know this, but they realized it and was like, oh, my God, we need to do better. And they created a different follow-up system, one of letters and phone calls. And this is the kind of news that you don't want to. I remember getting a suspicious finding on a mammogram. I came home maybe 10 o'clock at night, letter from my physician in the mail. I about passed out thinking, oh, my God, this isn't how we communicate news like this.
No.
So an example of a better step might be, and I've seen clinicians do this. Thank you for coming in. These are the tests that we're going to do today. We're going to book another appointment right now in 10 days or whatever the turnaround is so that we can come back and go through the results of all these findings. There are different ways that we can engage people. We can use electronic means over secure systems to have conversations with people. We can also invite them to come back into our care and understand what we learned and what these initial signposts indicate and what the next recommendations are, keeping that continuity of care going. And all of that, they're relatively straightforward things to do that, again, they privilege the consumer of care. They put them at the center of it and make it about them, not me checking my boxes that, yes, I sent it out, and here's the certified receipt, done, bye, move on to the next thing.
Right.
I think we can do better, and that would be an example. And I would challenge people, if our clinicians are not doing that, we need to turn to them and say, hey, look, you ran all these tests and everything. I'd like to know what the results are. Can I call you back? Should I come back in? How do I learn what these results are? And advocate for ourselves about how to be good stewards of our health.
So once we get past this barrier of bad news or the fear of bad news, and this communication crisis almost, right?
Yeah.
So if we can get past this communication barrier, do a better job of communicating, hey, this is what we're going to do, and now we'd like for you to come back and talk about what we did. So once we get there, and then we have this conversation, because the other point that you make is talking about meeting people where they are, and for the patient to become that center of care.
Yes.
So once they're in the office, and you have them there as a clinician. If I were a clinician, thank goodness I'm not.
I'm glad that they exist because I blood kind of makes me queasy too. So,
yes, no, I can't do that. I can only fix my child, right?
Right.
Blood on my child somehow doesn't have the same effect as everywhere else. But
yes.
Once we have these patients in the door as a clinician, how does the conversation need to change?
Well, I think part of the way the conversation needs to change, and some of the things that I've seen are we're moving to a broader teamwork, a framework of what a team is. Clinicians are very skilled in very specific things, and I'm glad that we have them. This ability to diagnose and treat. A diagnostician saved my mother. Simply put, she had a weird, strange, rare form of cancer, and he recognized something and followed the mystery to the conclusion. Had he not, she would not have lived. So there's a very high skill there. But they don't, the time and the energy and the skill that it takes, we need to have them seeing more and more people, right, doing that skill. So we need to bring in other people within the healthcare setting, right? So here the clinician comes in, talks about the diagnosis, the prognosis, what we're going to do. That usually goes in people's one ear and out the other because all you hear is the C word, and you just sort of, it sounds like,
the Charlie Brown teacher.
Charlie Brown,
right.
Yeah, and it's just, yeah. So we need to say to people, bring your trusted person in with you. Have someone come, friend, family, ally, to take notes, because then we're going to have you talk with the support team. The support team might look like a social worker, a master or PhD level nurse. There's a whole other layer of folks that come around for the sort of human-centered part of, now we have this diagnosis, we have a prognosis, we have a treatment plan, but what does that really mean from a cultural and social perspective? Like, what do you need? What are your hopes and fears? What is important to you about getting through this? And let's create a treatment plan that takes that into account. And it's really putting the patient in the center of this conversation and wrapping the services around them so that you don't feel lost and uncertain about what was said, okay, and what was done. And one of the things when I've taught medical students about this idea of informed consent, we want to inform you and get your consent to move on to the next thing. I always ask the students to check themselves to see, imagine themselves now as the clinician giving this information and giving a treatment plan to make sure that the person they told it to understood by asking this key question. So I'll pretend I'm going to ask you, Susan. All right?
Sure.
So, Susan, we've talked about a number of treatment goals and things that are important to you. When you go home tonight, and I should know who your best friend or significant person you're going to talk to, what are you going to say to him or her? I want to make sure that I explain to you everything. Tell me what you would say. And then I need to sit back and listen to you repeat that. Not word for word, but as you understood it.
Because oftentimes what we say and what people are hearing are two very different things.
Vastly different things. Vastly.
And when it comes to the telephone game, back when we were kids, and it moves from one person to the other, and
exactly.
it's a funny game, this is no laughing matter.
Correct. And it requires that kind of time and sensitivity. And one of the things I've often said to people, and I want to make that point here in our talk, is that if you're not getting this, if you're going into a clinical setting and people are not responding to you in a way that's useful, I always, I sort of say it jokingly, but I do mean it. It's sort of like going to the salon, to the barber, to the beautician. You're getting your hair styled, and you're trying to explain what you want. You brought along some pictures. You're talking about this important upcoming event, your child's graduation or whatever that you're going to, and you really want to look your best. If that beautician isn't able to respond to you in a way that's meaningful, you're more likely to say, well, I think I need to go find someone else. We're not afraid of doing that. But somehow in these clinical settings, when we are feeling that we're not heard well, and our words are just falling on deaf ears, and people are not giving us the kind of respect and courtesy in exchange, we either take it or we leave and we don't engage. My argument is keep shopping till you find somebody who gets you and understands what you need. They're out there. They are out there.
They are out there, and it's interesting that you say that. We spoke earlier to a breast cancer survivor. Her name is Jennifer Felch. You can listen to her on another one of our podcasts. And she says specifically, you should spend more time shopping for your healthcare provider or your doctor than you do looking for a new hairstylist.
Mm-hmm.
That's specifically what she says.
And I don't know Jennifer, but
no.
Yes.
But that was fabulous. We tied them both together and you didn't know, but that's
right.
But it's exactly that same point. Look, making the patient and you as the patient, even if there's nothing wrong with you.
Exactly. I think we are all sort of in the civil world that we try to exist in. We are broadly taught that, clinicians and other persons of authority deserve some kind of deference from us, right? Mm-hmm. That, we shouldn't talk back. We should just sort of, yes, doctor, I understand. Mm-hmm. That we don't engage. We don't wish to take up too much of their time. They're busy people. They need to see others. And while culturally we may have been past something that was important, respect people of authority, your authority is your life, and we need to respect ourselves, and it's a mutual give and take of that exchange. I am the authority of me, right? I know myself. I know what's important. I need to explain that to you, dear doctor, so that you understand where my power comes from and what's important to me, so that gets, I don't want that lost in this transaction. And we can't be afraid of pissing them off, if I can say that.
Sure, you can say that.
Okay, we can't be. And if we do, that's not the place for you.
Right.
We need to go. I know there's somebody out there. I know that. I've met them. I'd like to believe that when I taught them ethics, I trained a few of them. And I think we have to re-empower ourselves, that we are the authority of ourselves, and if we are not getting the kind of understanding and confirmation of what we're afraid of, what we value, and the help that we might need for that, then we need to move on until we find that in a constructive and appropriate kind of way. We don't want to delay this process. We want to say, I think I need a second opinion. I need my records transferred, this kind of thing. And second opinion can come by word of mouth. Right. People who are survivors and can tell you about their story, who treated them. Would they go back again? God forbid if they had to. But if they had to, would they go back? I think those things are really important that we need to remember to put us at the center of this conversation.
So do you find that women of color tend not to put themselves at that center of that conversation?
I think
is it a cultural thing?
Yeah, I think part of it's a cultural thing. I think there is this myth, we call it the myth of the superwoman. We are so historically, traditionally, and at present responsible for everything and everybody that we tend to put ourselves last. We'll make sure the kids, get everything that they need, that they get all their shots and their physicals, and we'll hustle them from one place to another, from, basketball to swimming to football to dance to whatever. But we're the last ones to go to sleep at night. We're the first ones to get up in the morning, and it's like rinse and repeat. I don't have time to be ill. And there's some of it's very mythical about, black women don't have time to do this. That's for white women. Only white women can do that. You're a black woman. You don't have time for that. That's almost like being self-centered, or I don't know. I've never understood it. It makes me very angry, but I get it. And I think we have to remember that if mom's well, everyone's well. Okay? If I'm well, I can ensure to the best of my ability that everyone else is going to be okay. But if I'm not, I can't take care of the people that I love. So I think we need to think about switching that back up. And so my argument is, and what I'd like to see us do, collectively as women, is when our kids go back to school, in the fall, that we get our health and wellness checked too. All of them got to get, all their shots and this and that ready to return to school in the fall. We need to put that on our list. And for those of us who don't have children, we need to make a buddy system. On your birthday, take care of yourself. Start by getting your checkups, and then go do something nice with your friends and celebrate your birthday. But put your health first and do it annually and do it for yourself. Celebrate your life by taking care of it. I think those things are really important. And when we do it with buddies, it's kind of that accountability thing. All right, I'll go if you go. Okay, we'll go together. We won't. We'll let ourselves down, but we won't let our friends down. And I think that's true, just sort of among human beings. But if we get, a buddy to remind us that we are equally as important in this and need to take care of ourselves, then maybe we can begin to chip at these terrible numbers of 44% more black women are likely to die from breast cancer than their white counterparts. That's got to end. And we have to do this by rethinking about how we think about health, how we think about access to care, how we think about how we engage in care and demand more equitable care in terms of the quality, putting ourselves as patients at the center of this conversation, of being understood and heard and valued. Our fears, our concerns, our worries, they're legitimate. They ought be answered. If they're not, you're not in the right place.
The social determinants of zip code, access to care, and the quality of care you receive have to change if we have any hope of changing the breast cancer mortality statistic for women of color. Timely diagnosis and patient-centric care are the keys to that change. Be the change you want to see in the world, Gandhi said. In the Austin community, we see that happening with organizations like Circle of Promise, Sisters Network, and the Alliance for African American Health in Central Texas. Komen Austin supports all of them, and we hope you'll join us. A big thank you today to iHeartMedia for making each and every single one of these amazing podcasts happen. Thanks, Mike, for being our in-studio technician and making all of the pieces sound so good together. Thanks to our Komen Austin team who make lots of things happen behind the scenes, and to our donors who save lives every day by investing in the work that we do. Susan G. Komen Austin is an affiliate of the Susan G. Komen Breast Cancer Foundation. If you need resources, information, or just have a comment about this or any of our episodes, reach out to us. You can find us at podcast@KomenAustin.org and then visit us online, KomenAustin.org. I'm Suzanne Stone, and until the next time, be more than pink.